Thank you very much, Professor. We have the questions at the end of the next session. They are speaking to the same subject. So you can take your seat and then respond later. So, ladies and gentlemen, our next speaker is a human rights and advocate specialist with over 20 years experience in advocacy, strategic litigation and capacity building of diverse stakeholders to strengthen access to healthcare and human rights. She's a FIGO advocacy and communication specialist, working in collaboration with OBGYNs and healthcare professionals in Africa and beyond to prevent maternal deaths and injury and improving access to safe abortion, care, gender equality, and reproductive justice. She was a master's in the National Human Rights Law. Jameen Kaur, please, you're most welcome.
Hi, good morning, everyone. So I'm going to go through a bit of a kind of a whirlwind in terms of giving you concrete examples on what can be done and how you in your individual capacity, each and every one of you individually, but as a community can strengthen access and implementation for sexual reproductive rights, and why particularly OBGYN's voice and skill and expertise is not only much needed around decision-making tables, but often it's missing. So it's really important that you take your place and see at these decision-making forums. So just to reiterate, I'm speaking on behalf of FIGO, but it's really important, and I'm here today with my colleagues, also Dr. Simon Peter Kayondo from the Uganda Professional Association and Dr. Dan Kay, who are very much part of this project. You know, what is FIGO? FIGO would be very hollow if it didn't have the ground power base of professional associations. FIGO's work is rooted on the ground. So FIGO's victories really are based on the work that you do in your individual professional associations. So I speak as FIGO, as a collective, as a community, as we are. So just to, sorry, I'm not sure if this is working. Oh, sorry. So I want to first kind of reiterate that when we talk about advocacy, this is one of the learnings, that advocacy can mean many, many things. I mean, this kind of cartoon kind of sums it up. When we talk about advocacy, you know, but based on where we are and what our perspectives, you know, we can think we're all doing advocacy. So let me give you an example. Research. Is research advocacy? Okay, that's a trick question. So research alone is not advocacy. Research, if it has concrete outcomes, what are we trying to change with our research? Is our research actionable? Does it have clear recommendations that we are trying to then develop, ensure transformative change? You know, research is very, very important. So I'm not stating that it doesn't have value, but there are a lot of academic projects. Does that actually lead to concrete change in real time? You know, sometimes it does, sometimes it doesn't. So I'm talking about advocacy in terms of, sorry. Do I need to click here? So when we're talking about advocacy, what we're really talking about is really harnessing kind of and honing in and focus. So advocacy really is an activities by individuals or groups that are there to really influence decisions and priority settings. And these could be within political, economic, social systems. But what we're looking at is transformative change. So not research for the sake of research, not data for the sake of collecting data, but what do we want to do with that data? What do we want to achieve with that evidence? And most importantly, we want to influence decisions, you know, government policies, inform laws, but inform cultural and behavioral changes. So why is it important? I mean, it may go, without saying why OBGYNs are important, but just to give you an overview, because sometimes I think our two communities, human rights and clinical world, sometimes we work in silos. And I really want to, if you have one takeaway, I want it to be this, that without clinical data, we wouldn't have the human rights legal frameworks that we do. So we have a symbiotic relationship. And what does that mean? So maternal mortality and injury, it would never have been seen as a human rights issue if it hadn't been for your data highlighting the patterns, the trends, that this is an injustice, not just in terms of the numbers, but also why is this happening? So yesterday, we talked about how we cannot just talk about clinical alone. We've got to look at the social determinants, because a lot of our work really is, yes, we know the leading causes, perhaps, of hemorrhage, unsafe abortion, but really what is the leading cause of maternal mortality and injury? The leading cause is gender inequality. That's what's rooted, and then it has symptoms and offsets in its other areas. So again, it's very important that we look at clinical data and human rights. The issues that we are working on are not just in terms of clinical, very important, but maternal mortality and injury, it's also a social justice issue as well. Again, we're in a world, we've heard about fake news and facts and stats. We have a lot of information, a lot of facts, but is that enough? And, we are at a stage now that, no, it's not enough. Clinical data and evidence is important. But most importantly, when we are in those decision-making forums, not only are we talking to the mind, we've got to speak to the heart. And it's the heart that we need the human story. And you as obstetricians and healthcare workers, you're on the front line. So you see day in, day out, the daily realities of not just of women and girls, of when they don't have access to safe abortion care, the example I'm going to be giving, what that happens in terms of their health implications, but also what happens to their communities, their families. But also as OBGYNs and healthcare providers, what are your lived daily realities when you don't have access or support, or you're not enabled by laws and policies to do your job? So that human story is really important. And often if you go to any decision-making forum, yes, we'll have numbers, but what do we take away? We take away the human story, because that's what impacts us most. And if you go back to even what your desires and motivations were, I'm sure you were influenced by, even within your own communities, of why you are taking these seats at this table today. Why did you yourselves become an OBGYN? And I'm sure that was influenced by, the human story itself to achieve change. So the human story is really important, and that's what you bring, and that's really your gold dust in addition to evidence. Then you are a community. As Bellington said, you are spread everywhere. So not only is your evidence and your findings, from your individual national perspectives, but you are part of communities at capital cities, in the regional outlets in your countries, but also regionally, and that feeds up globally. And what does that do? We know that when we have people around the table from different perspectives, then you get the best solutions. So that, again, is critical, and that is your real added value when it comes to advocacy. Again, as Bellington mentioned earlier, you have close links to the Ministry of Health. That is a core decision maker. When we're talking about advocacy, that is a key target for our work. As OBGYNs, you have VIP access, many of you, I'm sure, in terms of collegial work, and you're a trusted source. And trust in our work, particularly advocacy, is key. Trust brings also credibility. So already, you are in the room and you have that kind of legitimacy to share your insights. And that's often the biggest hurdle in even trying to bring change. And then close links with civil society. Again, we don't work in silos. And a lot of our work is informed also and built on the back of women's rights groups. They have been fighting this struggle for gender equality for a long, long time. Different perspective, adolescents, young men we need to involve in our work. So again, looking for unusual suspects. And I'll give you some examples of how some of the professional societies we work with really looked at thinking outside the box. And finally, you're impartial. time and time again, we're in a world where fake news now seems to be the headline. But if you look at, there's been many surveys conducted in many countries by the public. And one of the most trusted sources is healthcare providers. So that includes OBGYNs. The public trust what you say. And when there is trust, then we can leverage that to build people power. So in terms of just kind of facts, and I'm sure you probably know all of these, and if anyone's interested, I've brought a small kind of booklet that highlights some of the case studies I'm going to be talking about, but also facts and stats. You know, the issues we know are based and rooted in fact, and they have clinical evidence. You know, is abortion common? Yes. Is abortion conducted in restrictive settings, illegal settings, even when the law completely prohibits? Yes. You know, abortion is, 6 out of 10 unintended pregnancies end in abortion. 3 out of 10 of all pregnancies end in abortion. So that is a fact. You know, often we talk about, and if I want you to think of the analogy of the glass half empty, half full. Often our starting point is always, abortion is not legal. It's a fact that in nearly all countries, apart from a handful, access to abortion is legal in the law. Access, on the other hand, is an issue. But in terms of our starting point when we're talking about advocacy, we should start off with our patients, with our advocacy targets, that yes, abortion is legal, because nearly all countries, apart from a handful, have a ground for abortion. So we need to frame, when we're talking to the media, that we change the way we talk about language to reframe it as, yes, it is a right. And then there's other facts. Exclusion. We talked yesterday a lot about human rights and how healthcare is very important in framing human rights law. But it's important also of the human rights legal framework started on the what rights should be protected. So for example, civil rights, the right to health. We are increasingly moving into a world of who is most highest at risk when that human right is violated. It is abortion links to many systems of power. And when it comes to exclusion, as Bellington said earlier, it is women of color, it is adolescents, women living in poverty, women living in rural areas. They are higher risk to unsafe abortion, therefore maternal mortality and death. So again, we need to focus on the who as well, in addition to what we want to achieve. And then we've talked about COVID a lot. And COVID, again, has been a very tragic, unprecedented event in our lifetimes, and we are still going through it. But COVID has also given us a silver lining, and that is telemedicine, and that has revolutionized, in some parts, healthcare. We should seize that revolution and take it forward. So these are all facts. But then why are we still in the situation we are in if we know what the facts are and what we need to do? So I'm going to play a little game now. And this is just to kind of give you a quick overview. I want you to focus on the colors, on the color. So if you read from 1 going down, so green, please humor me, green, red, purple, green, purple, blue, yellow, blue, red. Okay, we're going to go quite quickly. So, but I want you to focus on the color, okay? So, green, red, purple. Okay, we're slowing down. And the last slide. Green. Okay, so what happened there? So we know that there was a time lag, right? So you saw something in front of you, the color, but you saw the word. And there was a time lag in between what we were seeing and what we actually thought. In that time lag is where you see unconscious bias. So even when we have facts and stats and evidence, because we have often unconscious bias, that vacuum, which is often filled by, how we grew up, what was told to us in the media, that is a fertile ground for abortion stigma. And abortion stigma literally it's a construct. And it looks at how, women and girls' lives what it basically sets these notions of what it is to be a woman. And these constructs are actually within power systems of patriarchy, capitalism, also white supremacy. Most of our abortion laws, as we know, are a legacy of colonialism. And when you have a construct that tells you that something is bad, it is shameful, it was immoral, that feeds into the laws and often even the way we talk about things. But when something is constructed, it can be dismantled. And that is our role as advocates, as change makers to do. Abortion-related stigma doesn't just impact women and girls, it impacts healthcare workers too. So there was a finding that up to 60% of nurses and physicians who provide sexual reproductive health care, they stated that they faced abuse and intimidation. And stigma is related to, also has shame. So that's internalized individually. And women and girls, and sometimes even healthcare workers, they say that they're made to feel ashamed for providing access to safe abortion care. For doing their job, they're made to feel ashamed. So what has been some of the strategies we've looked at within with our kind of colleagues at professional associations? So I'm going to give you a quick overview because I know my time is tight. But what is the antidote? Stigma and shame cannot survive when there's compassion, empathy, kindness. And for us, we need to unpack ourselves. So as previously mentioned, our colleagues, Dr. Simon Peter Kayonda and also Dan are going to look at value clarification, attitude transformation. And that has been a critical foundation for us to do our work. We can have, guidelines. Guidelines are important, laws are important. But if women and girls are coming into healthcare centers and they are feeling humiliated, disrespected, healthcare providers in those healthcare facilities are also feeling the same from their colleagues, then we have a problem. So this is just some of the work that the Uganda Society has done at looking at unpacking and looking at values and clarifications of healthcare workers, which is something that you could take forward if you were interested. And that has led to an increase in safe abortion services. And also it's looked at judgment-free healthcare delivery. Similarly, Kenya also did the same, but they adapted the materials to their local context. Mozambique, again, the value out of obstetricians is to harmonize the delivery of healthcare. So often, even within the Ministry of Health, there was a kind of a fractured approach to providing safe abortion care services. So the society there really worked to look at a checklist and to ensure that then there's a harmonization of standards across the board, which then led to better data collection and informing better healthcare systems. Zambia looked at kind of safe choices, really working with adolescents, again, a high risk group, looking to peer educators. And that was very important because, again, often young people particularly are getting misinformation or resorting to getting information from their peers, which may not be clinically sound. They also worked with unusual suspects in a sense of marriage counselors. Again, these are embedded in the community and they have access and they can provide judgment-free information with regard to where women and girls and communities can access safe abortion services. I'm just going to give you an overview in terms of this is just the project and some of the countries that we worked in, and you can get further information here. And just in terms of how does this all link up, right? Because we are all the sum of our parts, greater parts. So again, this is the kind of some of the work that the societies, professional associations have been working on with FIGO in terms of timeline. But again, we have looked at also trending, groundbreaking areas. So, for example, it was our member societies' evidence that was used by the UN experts to state what is the state of sexual reproductive rights in crisis, conflict situations. Because again, often that is forgotten. What needs to be done in so-called peace times to ensure that when a crisis does take off, what enabling environment needs to be in place. Again, just recently in August, we looked at racism has an adverse impact on health. And that we used, again, worked with our colleagues to look at their testimony and their evidence. We're looking at global campaigns. One of our key global campaigns at the moment is looking at the impact of defending defenders of sexual reproductive rights. So again, yesterday we talked about Roe versus Wade. There's been about 9 killings, murders of OBGYNs. That's called domestic terrorism in the US. And that's happening also in terms of imprisonment, jails. In Kenya, healthcare offices, healthcare centers have been raided. There's been extortion by police for money. So this, again, we're looking at in terms of highlighting the testimony and the on-ground reality of what can be done. And finally, Roe versus Wade, this is my final point, I can see the sign. We've talked a lot. And again, what's been absent previously in these discussions is the impact of healthcare workers. And we have to ensure that this is a global, healthcare workers globally are taking a stand. So over 300 healthcare organizations from over 90 countries have stated that access to safe abortion care is a human right and that their governments must not roll back. So this is something that you can get involved in if you want to as well. And finally, these are just kind of areas that we're looking forward to. Like if you want information on reports, FIGO statements, we are also trying to secure more funding to further this issue with regard to safe abortion care. And this is my last slide. I just extend a kind of a welcome, really. We are going to continue these discussions throughout, in coming months, but we will also be having a World Congress in Paris. So I hope you will all be joining for that. Thank you.
Thanks, Jameen, for the passionate advocates talk. Now, on that, a few questions, both Professor Valiga and Jameen Kaur. Please raise your hand if you've got a comment or a question. Okay, right in the corner there. You can continue raising hands so that you get mics. Okay, one day.
So first of all, I would like to congratulate both presenters for their nice presentation. My question is to the last presenter. Knowing now that the Roe versus Wade was turned down by Supreme Court of US, what challenges do you expect in this sub-region and Africa regarding the rollout of safe abortion care service? I am from Ethiopia, and I'm the Vice Secretary General for Ecsacog as well. In Ethiopia, we have liberalized the abortion law back in 2005, and then since then, the contribution of maternal deaths from unsafe abortion and abortion complications have significantly went down. But now we have started to see some challenges from the pro-life group, claiming that even in US, now the pro-life group have started to create a challenge. So my question is, what opportunities do you have to expand the safe abortion care service in this global scenario? And then what challenges do you expect in increasing access to safe abortion care service? Thank you.
Yeah, thank you so much for your question. And it's a very important question because, again, we are in a world where not only is it important for us to further the human rights and evidence-based agenda, but it's also important for us to hold on to what we have. And Roe versus Wade is a regression, it's a step back. And we have already started to see the ripple effects of what's happening. So, for example, in the EU, there's already been a rollback. I'm from the UK. our own government is also sliding. So, and they're stating that even our health minister stated that Teresa Coffey said that, prefer women not to have abortion care. So what was once seen as a right, there's a sliding erosion already of language. Hungary, you may know, has actually cut and pasted. Often you get cut and paste legislation. The heartbeat bill of the US. We are seeing regression also in other, Poland, for example, as well. So I think, yes, there is going to be an impact, because often they say that if the US sneezes, the rest of the world gets a cold, and we are seeing a rollback. But I also take confidence in countries like Sierra Leone. So I'm not sure if you saw, but as soon as Roe versus Wade came out, in June of this year, Sierra Leone, the government, there was a regional conference in West Africa, and they stated that we stand by women and girls in our country, and we will, protect the right to safe abortion care. And I think it's important because this is. I'm not sure if you can hear me. We had to be very careful in terms of how we responded to the Roe versus Wade decision. So as a healthcare community, we came together, and what we didn't want to do is give fuel, give oxygen to the anti-choicers. Because they will see it even as a victory for them. So what we did was we stated that the US is out of step. It is backward in its thinking and it's out of step. And that language has really resonated with the US decision makers, because obviously no one wants to be seen as backward or out of step. And you will see even in their media pickup, they'll say we're not out of step, and they'll go on. So, but if we look at other countries, like Latin America gives us great confidence, like Argentina, Chile, Colombia. So I think, yes, while it's important that we look at the implications of what's happening in Roe versus Wade, we cannot just sit and do nothing. We must also look to kind of countries that are taking this agenda forward, and there are many.
Thank you very much. I think we just take one more question. There's the end.
Thank you very much for these discussions. Considering the challenges which countries are facing, and the populations and advocacy groups are facing with abortion care, what measures are being taken to strengthen access to contraceptive use among the youth and women of childbearing age, and IEC programs to help prevent unwanted pregnancies?
Thank you very much, Dr. Amsterdam. This question is directed
directed to both presenters.
Who wants to take it? Prof, do you want to answer?
My question is, we are getting this problem of access to safe abortion care. Now, obviously, when women are considering abortion, it means there's either failed contraception or lack of access to contraceptive care, lack of IEC to empower women to be able to access contraceptive choices. What I'm asking is there also a parallel effort to strengthen contraceptive use to prevent these problems of unwanted pregnancies? That's what I'm asking.
Thank you very much for your concern. I don't think that I've got the right answer that can cut across the different countries that we are coming from. For example, with regard to access, I know that in some places the access is restrictive, and possibly that's where our role comes in, as members of the profession of obstetrics and gynecology to have the advocacy that I talked about. And obviously, if we are talking about access to contraception, again, problems are different in different countries, which range from commodity availability, trained personnel. So really, there's no single answer that can cater for all of us. But if we take into consideration that access to safe abortion and contraception are rights in sexual and reproductive health, then we are the best people, wherever we are coming from, to advocate that these women and girls access these services. Thank you.
So maybe just to answer the question which Dr. Mseta asked. In Zimbabwe, we have one of the highest contraceptive prevalence rates in Africa. I think we stand at about 67, is that? Yeah, it should be, it's very high. But in the study we did to estimate the incidence of abortion, in 2016, there were about 65,000 abortions. And again, majority come from people with unintended pregnancy. So despite a seemingly high contraceptive prevalence rate, it would appear there's so many people who still want to have an abortion. So it's really a very complex issue. But anyway, thank you very much for speakers in this session. So we are now going for the tea break. But while I have your tea, please, we've got a poster presentation. We've got presenters who couldn't get time to do the oral presentations. They worked very hard to produce papers and some work, which they want you to read and they want you to quiz them. So please, as you go into the foyer, the presenters will be standing by their posters. Do quiz them and also learn from the work they've done. Otherwise, we'll be back. Is it how many minutes? Maybe we can have 20 minutes. We'll be back and then we'll continue on the next session. Thank you very much.